That's the reason it's called a shared savings program and a shared risk program is it's shared. So you can't have a dark partner. So we need to do this together, all right? And what I'm going to show you is MVP's commitment in doing that, to offload some of the daunting burdens out there. I commend the efforts done in Buffalo and in other places where you have sophisticated platforms but the vast majority, they're not there yet, and the hesitancy and angst is quite palpable when I go out there. So here's our commitment. So first, it is a journey of partnership. And we do need to align our incentives. Apologies to Vincent for the extra U, but truly, if we do ordinary things in an extraordinary manner, if we get the attribution right, if we get the data and analysis right for quality improvement to make it actionable, if we get the financial data and make it transparent, because it's part of the triple aim to bring down cost. If, again, we fall back to data, just resonating on the themes earlier, and we exchange data, and remember, exchange means both ways, right? If we collaborate in care management activities, not everyone has a centralized care management organization. And if we truly engage and listen, that's our partnership commitment for transformation. So when you talk about transformation, the word, you do the scan the word universe when you ask someone what is primary care transformation, you get a lot of things, right? And so it's true, right? It's the most responsive organization that will survive. And the ground is shifting. It's not California, but the ground is shifting. And I would hope that the fact that you're here, you are scanning the horizon. Kudos to you. What I'm concerned about are the people who are not here and the ground shifting. And we want to address the quadruple aim, not just the triple aim. And again, it's back to that. Bring back the fun in practicing medicine for me as a primary care physician. And we try that by trying to provide the tools and support, not just to big ACOs or IPAs, but actually to the providers. And we're not even talking about a preferential treatment of, we're going to support people in the VBP arrangement. No, primary care physicians are facing the same challenges, perhaps not in a contract in front of their face, but the healthcare landscape is changing and they need support. And so yes, we support the transformation in value-based payment programs, but beyond that, we approach it in a more integrated and holistic manner with a big tent, all comers. We produce support tools like reports, not just for VBP partners. We try to elicit the exchange of care management data, not just with VBP partners, but the end goal is towards this journey of better outcomes for the population, better experience, lower cost, better quality. So what do? We align our functional units and areas. So we developed purposely, again, for the roadmap with value-based payment programs is we developed a population health management specialist program, which was not there 2 years ago. I was charged with getting this up and running. We have quality leads that assist in communicating opportunities with primary care providers. We have provider relations that go out, again, to the offices to explain contracts, to explain why the check didn't come in the mail. And we have the value-based arrangements. And also retail outreach. So these are the ones who enroll Medicaid members to help them renew, or perhaps to enroll for the first time Medicaid eligible. And we'll show you why it's important. So again, the contracts by themselves are only worth the paper and ink on them. Once you sign them, if you do not follow through, it's worthless. And so we have supported, from our history, we've supported initiatives that resonate as value-based care programs, the PCMH program, the CPC Plus program. You heard me talk about that this morning. And basically, we've used different value-based arrangements, even as I said before the roadmap was in play. Quality incentives, shared savings risk, and capitated primary care payments arrangements. So I like this because again, if you're accountable, you respond. You pick up the phone. You engage. You're not accountable, you don't pick up the phone. You don't engage. But as I said this morning, just because they do not show up in your office for 2 years doesn't mean they're not your patient. All right? And again, we're talking about Medicaid, right? So this is a Medicaid conference. And so they're assigned the PCP. And if you do not look at your attribution list of your panel, you may not know that you are the physician being evaluated in a harsh way because they did not get their colon cancer screening, their breast cancer screening, but they're on your panel. And so attribution is a fundamental thing that you need to look at. Who is in your population, who's in your panel. And it helps you with that power and knowledge of risk identification and stratification. And like I said, your accountability and responsibility in this new world extends beyond your office walls. We provide monthly rosters to all our VBP partners and strategic partners who may be eventually VBP partners and large practices. So again, it's this doing the small things or the ordinary things in an extraordinary manner, right? We're a regional health plan. We do not have an R&D shop. We're a non-profit, not-for-profit organization, and so we try our best to do the ordinary things in an extraordinary way, and we make it a habit. And so it's not just about how am I doing with the reports, but extending that, how can we do better? And so what we have is opportunities where we expose the gaps in care for any patient with at least one gap. We do the office visits, and this is a bit sometimes challenging because again, we're from the dark side, and I have not yet seen a party hosted when I show up. Let's put it that way. But I think that needs to change. Host a party for me. But so we do come bearing gifts. We don't catch us. So we go to the offices. We show them opportunities how to improve. If we look and see that it's not such a great performance for cervical cancer screening or colon cancer screening, then we give them suggestions, tip sheets. So is it an issue of codiness? Again, the themes resonate here. Is it an issue of coding? Is it an issue of documentation? Is it an issue of billing? All right? Do you actually fill out all the line items in your bill? Is it getting dropped from the clearinghouse? Is it getting into the health plan's billing system? So we actually do projects where we evaluate from soup to nuts. We identify high-risk members that haven't been at the office for 2 years, who potentially have historical high-risk diagnoses. And we do investigative projects to help educate on coding and seeing if there's something that's hindering the true reflection of their population risk. Utilization reports, emergency department, inpatient, as well as a standard reporting package that includes using the Johns Hopkins ACG risk score model. And so we give you a report of your population risk using the Johns Hopkins ACG methodology. So Terry Goodkind I believe is a nonfiction writer, and I think what his novel was Sword of Truth, his series, and this is, I think, one of the truths. Knowledge is a weapon, and again, primary care physicians, other than perhaps, freestanding physician practices where they are entrepreneurs and immersed in the financials, if they're not, and if they're not in a management position or attending the committees, as mentioned by Dr. Vasquez, a lot of us, physicians don't, right? We went to medical school, not business school, right? That's the fallback response, right? But the reality is, again, we are at the cusp of a healthcare catastrophe because we, the majorist stakeholder in the healthcare industry, shied away from this, right? And we need to get back. It's part of the pillar of the quadruple A. So the data provides the guardrails, right, for the appropriate utilization, right? You can't, it's great to have a 100% passing rate on cancer screening, but if you're, spending a voluminous amount of money, then there's a disconnect. So basically, it helps with risk readiness in a value-based arrangement by giving them a dashboard of their performance in different subcategories so they can sniff out where there's smoke, there might be fire. Is it in the inpatient utilization? Is it in the outpatient? Is it in the professional services? Is it in pharmacy? As again, the theme that was mentioned earlier. We also give high-cost patient reports. And again, it's interesting. There's so much alignment in what Dr. Vasquez mentioned about the pharmacy cost. So right now, the biggest cost driver in healthcare is pharmacy. It has exceeded professional services, inpatient, or whatever other service. I believe it's like now 21 cents to $1 to the dollar. Data. Data is powerful, right? And this is the author of Freakonomics. And the point here is it's not just, it's even more powerful if there's an exchange. Because again, as Dr. Vasquez mentioned, he knows things I don't. And that's really, the symptom of our fragmented, healthcare system. And the more we exchange data, the more we get closer to the truth. As they say, the truth's out there, right? And so, if it only gets if it's actionable and timely, then you can address the shifting landscape and the ground moving beneath your feet, and you get to be more informed. And so, this is key, right? How we act and make decisions can only be as good as the quality of the data and information that we have. Absent that, it's a crapshoot. So we recognize that different practices have different capabilities, as I mentioned, and we help both advanced providers as well as emerging practices to try to level the playing field. And so we adjust our commitment to the needs of the providers. And so by linking the clinical and financial data, that's really where we believe value comes from. So what are the actionable and timely data points? So again, as we mentioned, monthly claims extracts, member rosters, utilization reports, the patient risk detail to help you truly manage not just the obvious, right? We know what a train wreck looks like, but we're not too savvy on the rising risk member who, there's just small data points that suggest that they're going to hit that wall. And because it's not $1 million yet, we tend to focus on the $1 million, but guess what? The $1 million was spent. They already went to the emergency department 50 times in the past 12 months. They already got admitted 25 times in the past 10 months. Right? It's done. It's spent. You need to focus on the rising risk to minimize your losses on that pool of rising risk. So care management coordination, again, what Dr. Vasquez mentioned was I think he copied from my slide. Care coordination. And again, I will say, they don't teach that in medical school, right? The doc makes the decision. And that's old school. We will not survive in that scenario going forward, or today. We will not survive. And then lastly, the gaps in care, as we talked about. So again, to emphasize care management, it's about collaboration. Who recognizes Matty Stepanek? You do? Yeah. He died at 13. He had a genetic disorder, but at 13 he published 6 books, mostly on poetry. So we truly listen from the mouths of babes that it is about the teamwork and collaboration. Because we've tried doing it through the power of the prescription pad. We've tried it through pure forced capitation. You know, it's got to be teamwork. We need to all recognize the same prize. If we're not, then we're rowing in different directions. So what we do is we firmly believe that care management is the backbone for transformation in primary care. And so we, MVP, do direct to patient care management in the acute, chronic, and transitions, but we also support the providers in their own population health programs through the information, through the human resources, population health master specialists, quality leads, regional medical directors, myself, the vice president of quality, to go to where you are and have a conversation as to where we want to go. We provide other things like the risk identification, stratification, and as I mentioned, the pharmacy issue. So what else? So through our engagements, we realized that, well, maybe it's not realized, but we affirm that the system's broken. So one example of how we engaged this FQHC in the Mid-Hudson, so the member was admitted, 25 times in 10 months, 50 ER visits in a year. So what do you do, right? So they're doing their thing, right? They're care managing them. MVP's doing their thing, or care managing the person. And no one ever used the groundbreaking technology of the telephone. and sharing that, we've tried all this. Yeah, we tried all this. And when we got everybody together in the room, then we realized, oh man, we missed the boat here, right? And so we're developing a Medicaid complex member, high utilizer evaluation and escalation process. How many of you know of the ACT team program? All right, 2 out of what?
Everyone else.
So that's it. Okay, how many of you know you shouldn't raise your hand anymore.
You're too good.
You know everything. No, please do. Who knows about the restricted member program? There you go. So again, so what do you do with that member? 50 ER visits, 12 admissions in 10, 12 months. And so there are ways that, not there are ways, but if we consolidate our understanding of what you're doing as a primary care provider and what we, the health plan MVP in particular, is doing, then let's see, did we already refer that person to behavioral health? Is the behavior about a behavioral health problem? Did we already refer that patient to a health home? Is the behavior rising to the need for further support, right? And it's only once we ferret out, did we check all those boxes, right? The checklist that Atul Gawande talks about. If we didn't do that, we're just spinning our wheels. Okay. So again, it's about understanding from you, the providers, fathoming the problem, and coming with solutions together. Engagement. So I drive a Ford. and so basically, we do need to engage more, right? We cannot go forward without a trusting relationship. I know that's a hard thing, right? Especially when the checks come from us through the mail, and you want more checks, right? I mean, but the reality here is, unless we do engage in a more collaborative, trusting way, because it's mutual success or mutual fill in the blank. So we engage you through, again, the population health management specialist, through contract management, retail outreach, and provider reps. And basically, what the retail outreach does is, again, the lapses in insurance. So what is the churn rate of a Medicaid member? Who knows?
18 months.
Was that?
18 months. Do you have them on your side?
What is the rate of a Medicaid member lapsing on their Medicaid coverage?
Oh, it's probably very high.
Yikes.
They won't renew it.
30%. So that's 30% disruption in your cash flow. What are we doing about it?
Right. That's it.
What are we doing about it? We're trying to do something about it.
No.
All right? So we're trying to bring back the fun in primary care. We are, I'm not gonna throw Joan under the bus here, but
Throw me under the bus.
there you go. But we reached out to Joan, and we think we can help in connecting, your Medicaid, the population that are Medicaid eligible, or those who have lapsed, to again help her organization. Pre-visit planning. So from our exercise, well, not exercise, but of our project in evaluating soup to nuts, the true population risk of a subset of what we felt were high-risk members, the output is that we can identify other high-risk members and give you that information before they go to your clinic, or in preparation for their visit, or in targeting them for a visit, right? Identifying the ones that will help you reflect the true nature of your population complexity. What else? The provider relations, they have a dashboard that providers can access, and they can see claim submissions and denials. Again, the administrative headache, we're trying. I'm not saying it's going to solve it. I'm just saying we're trying. And okay, I heard that. I'll be done soon. Population health management specialist, what we're trying to do is, we realized that a provider had to know 24 telephone lines to reach MVP. And so what we said was that's on the verge of crazy. So let's try to, it's never going to be a single point of contact, but at least from the clinical side. Let's have a population health management specialist who will help connect the member and the provider to these obscure resources perhaps, right? It's the first time I need to refer to behavioral health. Who is it? I don't know. Our population health management specialist is the concierge person, similar to what's happening in Buffalo. And so they basically support the transition to value-based care through the delivery of information and quality and cost, establishing that trusted relationship, and basically helping in proactively identifying the risk of the population. We also collaborate with the PPSs. And this is great. As we know, Helen Keller overcame phenomenal constraints. But let's give kudos to the teacher, though, right? Jane Sullivan. So what we do is we have engaged with all our PPS partners that we have a substantial membership in. And so we are in the throes of helping with the development of curriculum and training on these areas of topics. So we approached the PPS and we said, we think that value-based payment is a topic that still needs to be disseminated. Yes, we agree. Okay, we'll join you. Quality improvement. You know what, health plan, you do that better. Could you be the lead? Yes, we'll help you. Risk stratification, PPSs don't do that. Health plan, can you help us? Yes, we'll help you. Coding and risk adjustment, PPSs don't do that. Yes, we'll help you. So we try our best, again, we try to collaborate with our PPSs. And so when we scanned all the programs or projects, we realized that it's a set menu of projects that they had to attest to or choose. And we found out that there are certain projects that align for all the PPSs. And so we're trying our best to collaborate with synergies with all these PPSs. And so also, because the PPSs are supposed to address the gaps in health outcomes, so we have programs that we're trying our best to align with them as well. Behavioral health portion, asthma, the neonates, little footprints, congestive heart failure, and the diabetes program. I know I'm over, but we're trying, so I hope I won your trust.